Welcome today. My name is Angie Hameli. I'm with the Caregiver Assistance Network at Catholic Charities, and we are having every month several educational presentations online, and we're fortunate today to be able to have Linda Anello with Vitas Hospice join us to talk about enhancing end-of-life care through hospice. And if you'd like information on any of our other programming, you can get that on our website at www.ccswoh.org and click on Programs and Services in the Caregiver Assistance Network. So I want to thank Linda for joining us today and sharing her wisdom. And I'm going to let her tell you a little bit about herself and Vitas.
Hi, everybody. My name is Linda Anello, and Vitas Healthcare is the nation's largest provider of hospice services. I'm a community liaison for Vitas Healthcare in the Cincinnati region, and that means that I do education programming such as this, and I also do something called the Goals of Care conversation, which I will go into a little bit more at the end of the presentation today. So I'm happy to be with you today and talk about how to enhance the end of life through hospice care. All right, so today we're going to go over the meaning and purpose of hospice care. We'll talk about the benefits and how hospice enhances life for the terminally ill patient and the patient's family. We'll go over how the hospice movement began, talk about some of the services hospice provides, how hospice is structured to meet the needs of terminally ill patients and their families, and then we'll go into how to identify a patient who is hospice eligible. So what is hospice? Hospice comes from the root of the word hospice is the same linguistic root as hospital or hospitality. So it suggests shelter, caring, respite. Originally, 5 Sisters of Charity from Ireland opened St. Joseph's Hospice in London in 1905. The first hospice in the United States was in New Haven, Connecticut in 1974. So hospice aims to manage a patient's pain and symptoms for quality of life. We help holistically, emotionally, psychosocially, spiritually with aspects of dying. We provide the needed medications, medical supplies, and equipment for end-of-life care, and also instruct the family on how to care for the patient. We deliver, in some cases, special services like speech or physical therapy when needed. That would be on a short-term, case-by-case basis. It can be approved for short periods of time with a specific quality of life goal. And Medicare Part A also will cover therapies for a separate diagnosis, separate from the terminal illness. We make short-term inpatient care available when pain or symptoms become too difficult to treat at home or in a nursing facility, or also in the case when a caregiver needs a respite for their own well-being. And then we also stay with the family, providing bereavement care and counseling for family and friends who survive after the patient has passed. That's for a minimum of 13 months. So in hospice, we have 4 levels of care. Routine home care is the majority of the care that we provide. That is, we aim to keep the patient at home where they're comfortable, whether that be in a nursing facility that they call home or their own personal home. It is always our goal to keep patients at home as much as possible. However, sometimes when they have a crisis, a moment of pain or symptoms that are out of control, they need a higher level of care. Intensive comfort care is that, and also inpatient care. And we'll go into more detail on these in the next few slides. And then respite care for the caregiver, which we've briefly mentioned. Okay, so in routine home care, we have a whole team of caregivers that provide supplemental care. So it supplements the care that the family is already providing or the nursing facility is already providing. So we make visits. The visits are determined on each individual's needs, and that individualized plan of care is adjusted as the patient needs more care. In that, we are assisting the caregivers, whether that be family or nursing home staff, and we guide the plan of care. So we're collaborating. And this is wherever the patient calls home. That's routine home care. And then in the intensive comfort care level, that is where the patient needs more time and attention. So a minimum of 8 hours up to 24 hours a day, and at least 50% of that care is provided by a nurse. This is related to acute symptoms that need to be managed. So once those symptoms are managed and the patient is stabilized, they would return back to a routine level of care. This has happened. So this intensive level of care is just during a specific crisis. Then in inpatient level of care, in the Cincinnati area, we have the Drake Hospital 5th floor as our VITAS inpatient unit. And that is for symptom management such as pain that's out of control, agitation, dyspnea, which is shortness of breath, wound care, or family or system breakdown. So for patient safety, they will go into the inpatient level. That I already mentioned that we have the Drake inpatient unit in Cincinnati, but in the case where we don't have an inpatient unit close by, we can also contract beds in other facilities or hospitals. And then once the patient is discharged, they're going to go back to routine home care. Respite care is again for the caregiver. For example, if the patient lives at home and their caregiver has to have surgery or is going out of town for business or just needs a mental health break. So temporary relief from the care that they're providing for a period of not to exceed 5 days. And that can happen periodically. So what are the ways hospice can help? We'll look at that next. All right, so we help with controlling pain and other symptoms that interfere with quality of life. We are also helping the patient and family to achieve a sense of control of their own care. So we really involve the patients and families in decision making. We educate them to be able to make informed decisions about their care. We help them find meaning in life. So we focus on what gives life meaning and what is quality of life for you and how can we help you to achieve that. And for example, in hospice, sometimes there are special family functions that the patient really wants to attend, a wedding, a birthday. So we will do whatever we can to help the patient attend, or we can bring that to the patient as well. We find many creative ways to help with meaning finding in life. And we help relieve the burdens of care for family and other loved ones who are caring for the patient. And so what's important to terminally ill patients? One of the things that's really important is that their terminal illness is acknowledged. Sometimes in society, because we're uncomfortable with emotions or pain and loss, we try to sugarcoat and maybe not acknowledge that this person is actually dying. The person who is actually dying knows that they're dying and they need to talk about it because it's a significant experience that they're having. So we help patients and families talk about the reality of that situation. It's really important for the patient to be seen as a whole person and treated with respect by their doctor and their care team. So not to be treated as their illness, but really to see their humanity. And they need to respect and trust their doctor to have their best wishes in mind, and also to be giving them the best information to make informed decisions. And they need an opportunity to talk about their wishes for how their end of life goes. I'd like to tell people it's really important how a story ends, and it's important that we know how they want their story to end. So we help them talk through that. All right, so pain is not just physical pain. What are some other components? So obviously, the first one would be physical pain, and we're all familiar with what that means. There can be a multitude of reasons for physical pain, but in addition to physical pain, there's also the pain that comes from anxiety, anger, and depression. And that can feel the same as physical pain. Those emotions of intensity can increase physical pain. In addition to that, when there are interpersonal problems, if they feel lonely, if they're worried about their finances, if there's tension in the family, all of these things can exacerbate pain as well. And then one of the important things that we work on in hospice is when patients are not accepting the fact that death is approaching, any kind of resistance increases physical pain as well. So we help the patient and family talk through and come to terms with their terminal illness. And once they do have that acceptance, that brings peace and helps to alleviate pain as well. And what do the caregivers want? They want to have their loved ones' wishes honored. They want to be included in decision processes, to receive support and assistance at home in a practical way. They want honest information to be able to make informed decisions. They need help. It's really hard to take care of a patient at the end of life, and they can become overwhelmed. And with hospice, they have 24/7 access by phone and in person to nurses who can help them around the clock, that come to them as well. So not that they have to go to a hospital ER in the middle of the night. They need to have someone listening to them, respecting their privacy. And once the patient passes, we don't forget about them. We contact them. We remember them. We know that even though the patient's life has ended, this connection hasn't ended for that loved one, and they still have a lot of processing to do. So how do patients' lives end? At the end of life, where do they end? So we know that 80% of Americans say they would prefer to die at home, but actually only 20% of them actually accomplish that. In order to accomplish that goal, it takes proactive planning. Having hospice on board helps that goal to happen. So in this graph, you can see 66% of patients died in their place of residence. So those first three figures, their private residence, a nursing home setting, and a residential facility, that would be considered their place of residence. In this slide from 2014, 66% of those patients died in their place of residence. And only 7% died in an acute care hospital. Well, I looked up the updated data for the current time, and what I found now is stats are saying 60% of patients are dying in acute care hospitals. 20% die in nursing homes, 20% die in their personal homes. So we really have not come any further. We've actually backtracked. But when a patient takes advantage of hospice, they have more control over when and how their life ends. And that really matters. So what we see in this slide is the correlation between the place of death and how that impacts physical comfort, psychological welfare, and quality of life. And you can see that this is patients and caregivers who reported on their experiences. This is a 2010 multi-site study, and we followed patients from enrollment in all four settings through death. And a median, this was in a median of 4.5 months. So patients' quality of life at the end of life was assessed by caregiver report within 2 weeks of death. And you can see here, and then the bereaved caregiver's mental health was assessed at baseline and 6 months later. But you can clearly see that in hospice, the physical comfort was by far more well managed. Psychological welfare in the second graph there, you can see that at home with hospice was the preferred or the most beneficial for psychological welfare. Hospice setting, not at home, is not the one next to it. But as you can see, every single time in the ICU or hospital setting, quality of life was negatively impacted. So keeping people at home where they're comfortable is definitely improving quality of life for the patient and the family. All right, so hospice services are covered by Medicare and Medicaid 100%. So this covers their nursing care, their doctor's services, any medical equipment or supplies needed for their terminal illness, any pharmaceutical medications or other drugs related to the terminal illness for the symptom control and pain relief, and a hospice aid or light housekeeping services. So patients with chronic illness in their last 2 years of life account for about 32% of total Medicare spending. That was a 2010 figure. So I'm sure it's more by now. In addition, as I mentioned earlier, on a case-by-case and short-term basis, physical and occupational therapy can be provided for a specific quality of life goal. Same with speech and language pathology services, but also social workers are part of our team on a consistent basis, and dietary counseling is available as needed. And then, of course, grief and loss counseling for the patient and family is always a part of our service. All right. Short-term inpatient care for pain and symptom management and short-term respite care are also part of the hospice plan of care as needed. And any other Medicare-covered services needed to manage pain and symptoms related to the terminal illness as recommended by the hospice team. So all about quality of life, managing pain and symptoms. And we see here a study about chronic illness being the primary cause of disease in America. All right, so the length of time, length of service in hospice. Most patients spent between 1 to 7 days in hospice care. That's 27.8%. We see between 2012 and 2017, the highest average length of service was 79 days in 2013, and the latest figure was 76 days average length of service. Hospice is meant for the last 6 months of life, but the average length of service is just a little over 2 months. So what we see here is that people are waiting too long to take advantage of hospice, and they're missing out on supportive care that they could have had for much longer. And what we hear often too is that really patients and while families say to us that they really regret they didn't take advantage of the service sooner. And here you can see too that the majority of patients only received the supportive care of hospice for 1 week or less. So they're really suffering through an overwhelming situation without the support that they could have because they're waiting too long to take advantage of hospice services. All right, so this talks about how many patients are taking advantage of hospice each year. So it is increasing each year. You can see 1.49 million Medicare beneficiaries took advantage of hospice care at the end of life in 2017. That was a 4.5% increase from the prior year. And 98% of the time, those patients received routine home care. Again, we're keeping patients at home where they're comfortable, where they want to be. And then in 2017, Medicare beneficiaries who died, 48.2% were enrolled in hospice at the time of death. So you can see there still less than half of people who are dying at the end of life are taking advantage of hospice services. And of those who did, 40.5% received care for 14 days or less. Again, going back to not taking advantage of the service or taking advantage of it too late. 14.1% received hospice care for more than 180 days, which is the 6 months that we aim for getting people to come on service when they have 6 months of life left. The problem is it's hard to know when you're in the last 6 months for sure. Okay. So what are the diagnoses that are bringing that hospice patients are coming to us with? So here you can see cancer, dementia, heart disease, and the other category were the top four. And this was in 2014. In 2017, the stats are pretty similar. Cancer is still number one, but at 30%. Circulatory and heart conditions at 17% as number two. Then dementia, again, at 15%. And then the other category, which includes things like respiratory, stroke, kidney, those are some of the other category. And those were lumped into the number four. So we'll go to, so yeah, okay, that's good. Thank you. So here are some examples of the other category that you can see. All right. So it's really important that everyone 18 and older has an advance directive. This is not only important that we have the paperwork so an advance directive is going to indicate who is the person that will make healthcare decisions for you if you're unable to speak for yourself. That's called the healthcare power of attorney. It also might include a living will if you would like to say, if I am permanently unconscious, I don't want to be kept alive on life support, for example. It might include donor registration forms as well. But these are advance directives where we're planning for the type of care we would want at the end of life. Only 37% of Americans actually have an advance directive. And you can see that if they are a hospice patient, we're going to encourage that. So 88% of hospice patients have taken advantage of getting their advance directives done. That should be 100%. In the nursing home setting, where the nursing home may be encouraging them and helping them to get that done, 65% of patients are getting that done. But when you're in a home health setting, only 28% of patients are having an advance directive completed. And look at the next one. With a severe terminal illness, fewer than 50% are having an advance directive. So that's a big problem. If you have a terminal illness and you haven't got your advance directive in place, that leads to a lot of crises as things get worse toward the end. Even if you have an advance directive, often physicians are not aware that you have that, and they're not aware of their patient's wishes. So it's really important not to just have the piece of paper, but to have conversations with your physician about your wishes. And 38% of those patients who died spent more than 10 days in ICU. So again, we go back to patients want to have a peaceful death at home, surrounded by family, but without that advanced planning, more and more patients are dying in an ICU setting. Half of those patients had moderate to severe pain, greater than 50% of the last 3 days of life. And with hospice care, we are managing pain and symptoms to enable a peaceful and a quality of life at the end of life so that there isn't suffering. So that's the kind of if you think about it, without planning, that's the default in this country, is that you're going to end up most likely dying in pain in an ICU without your family around if you don't take advantage of planning ahead. Okay, so who qualifies for hospice? Let's look at that. All right, so a patient must be deemed terminally ill, and 2 physicians are going to make that determination. The attending physician and the hospice medical director are going to concur that if this patient's disease runs its normal course, their life would be expected to end within 6 months or less. That's the initial eligible status, okay? And then once a patient is certified as eligible, they are entitled to 2 90-day election periods, and then following that, an unlimited number of 60-day periods. So the attending physician and the medical director together certify in writing at the beginning of that first 90-day period that the patient is terminally ill. And then we are constantly keeping an eye on that patient's eligibility. If at any time that patient is determined that they have stabilized, that they're no longer terminally ill, that they don't qualify, then there is the requirement that we would discharge that patient. The other side of that is if they remain eligible, then they have an unlimited number of 60-day periods where we're constantly evaluating that. So even though we said earlier that if two physicians would determine that you were terminally ill with a life expectancy of 6 months, if you are still eligible and 6 months has come and gone, we don't kick you off of service. You stay on an indeterminate number of benefit periods. So that means we have had hospice patients on service for multiple years, actually, which is something that a lot of people don't really expect, or I think one of the problems that we have with people waiting too late to take advantage of hospice is because they think that hospice means, actively dying, and it does not. So that's one thing that it's important to know. All right. So for the recertification periods, the hospice physician is the only one that at that point needs to continue to certify that the patient is terminally ill. And then prior to the beginning of the patient's third benefit period, either a hospice physician or a nurse practitioner must have a face-to-face encounter with the individual to determine that they stay eligible. Prior to that, they can look at documents, medical records. All right, so one of the main criteria for hospice eligibility is that the patient's goals are in line with hospice model of care. So hospice is about quality of life, managing pain and symptoms. We don't do anything to hasten death. We don't do anything to stop it. Okay, so we're just helping manage pain and symptoms for quality of life. So if the patient's goals are quality of life and comfort, and not aggressive treatment, then those goals are in line with hospice care. So if the patient determines that aggressive treatment is causing more burden and not giving as much benefit, so they're kind of weighing that, what's the burden of treatment versus the potential benefit, and is it worth it for me? And if they determine, no, this is no longer worth it, I want to focus on quality of life, then that it would be a consistent goal with our hospice services. And maybe no further medical interventions are even possible. Maybe a physician has said, we've done everything we can, and at this point, we have nothing more to offer in terms of aggressive care. So that would be another case where a patient would then at that point consider comfort care. In addition, we look at functional status. So activities of daily living would be, some examples of that would be the ability to eat, bathe, dress, toilet, continence versus incontinence, transferring from, one setting like a chair to standing or to a bed, transferring between settings like that, ambulation, moving about. So those are some of the activities of daily living that over time, as illness progresses, people need more and more help with those. So if they need help with 3 out of 6 activities of daily living, then that would be an indication that hospice would be something to look into. It says non-cancer patients here because the criteria are different for each diagnosis. And in cancer patients, it's not necessarily the case that you would have to look at the 3 out of 6 activities of daily living. Unintentional weight loss. So we see a dramatic decrease in body weight, not intentional. Their body mass index as well. So this happens because people either are unable to eat, they've lost the desire to eat, they're unable to maybe process food. There's many reasons, but we see in advanced illness, unintentional weight loss is one characteristic. We see an increased utilization of healthcare resources, multiple hospitalizations, multiple emergency department visits, other types of specialists. So as illness is advancing, patients are taking advantage of healthcare services more and more. And what we notice too is, like, especially with chronic illness, patients get very used to that kind of cycling in and out of the hospital and having exacerbations, and then things stabilize. And sometimes they don't realize that, they don't take a step back and look at, oh, this is really like becoming more frequent, and returning to baseline is not happening. With each hospitalization, we're seeing further and further decline. Disease is progressing. So a physician's assessment, lab tests, diagnostic studies are all indicating this disease is progressing, in spite of everything that we're trying to do with interventions, whether that be medical, surgical, or pharmaceutical, whatever we're trying. In spite of that, the disease is still progressing. It's not working. Comorbidities are increasing. So we start to see, maybe in the beginning, there was one organ system involved, heart or lung or another, and then over time we start to have more comorbidities. So kidneys start to get involved, for example, or you start with a heart problem and now you have a lung problem, or vice versa. So we just start to see more and more complex medical care needed. In a long-term care facility, they have an assessment called the minimum data set, and they're looking at that as well. So that, they'll be able to notice that the patient's illness is advancing by that. And then the home health care providers also might notice a decline in functional status. All right, so that's general criteria, but each disease has specific criteria. And if you're watching this and you are curious about a specific disease and what the criteria would look like, please feel free to contact me, because I do have additional information I can provide that's specific to disease state. So we did talk about comorbidities that influences eligibility as well. So you may have one disease state and you don't meet all of the criteria for hospice based on just that disease state, but then the comorbid conditions complicate your overall picture of health. So that can play a role in determining eligibility. So it can get complicated, and that's where we have VITAS experts to evaluate case by case. What does this look like? Is this patient eligible for hospice, and what can hospice do for this patient? So I always encourage people to take advantage of an assessment as early as possible. Even if you think it's too early, this patient is not eligible, it never hurts to have an assessment. There's no cost in that. And then that assessment, you can get education about what to look for in terms of symptoms and factors that may lead to eligibility in the near future. In addition to that, we will follow up too, to make sure that if you become eligible later, we're keeping an eye on that for you. So in conclusion, the goal of hospice care is to address the factors important to terminally ill patients and their caregivers, to manage pain and assist with other end-of-life aspects, not just physical pain, emotional, psychological, holistic care for the patient and for their caregivers, and to support caregivers after the patient passes. Depending on the patient's needs, hospice offers the 4 levels of care: routine care in the home, intensive comfort care in the home, inpatient care, and respite care. And then we have found that both patients and caregivers report higher levels of quality of life and comfort when the place of death is either a hospice setting, an inpatient unit, or in their home, instead of being in the hospital or ICU. We want to avoid death in a hospital or ICU setting if at all possible. Qualifying patients are granted some financial relief, as hospice care is fully or partially covered by Medicare. And cancer is the most prevalent diagnosis, but there are many others. And so, again, contact me for specific disease criteria. All right. So again, we want to impress upon you the importance of advanced directives, because planning in advance increases the chances of patients receiving the kind of care they wish. Now, in addition to an advanced directive, which is the document, it's really important, more so the conversation as much as the document. So in-depth conversations, frequent conversations, are really important. And that's something that I help people do with the goals of care conversation. This is a free service that we offer, and you don't have to be planning, you don't have to think that you're hospice eligible now. It might not be a year, it might be 2 years before you're eligible. But you might just want to be proactive and plan ahead and talk about your goals for the future. It's especially important to do that while you can. So I would strongly encourage anyone with an advanced illness, especially too, if you think about a dementia diagnosis, because you know that over time that person will have an increased difficulty expressing their wishes. So we want to make sure we do that early and often. So certification is required in order to be, for the eligibility to be determined, and recertifications are needed for subsequent election periods. When determining prognosis, specific clinical conditions that meet the requirements apply for each illness. Again, case-by-case basis, and best to have an expert do an evaluation for you. All right. So if you have questions about this presentation, I am very happy to answer those. My name is Linda Anello. I'm a community liaison with Vitas Healthcare. My phone number is 513-658-8051. And my email address is Linda, which is LYNDA, .Anello, ANELLO, at Vitas. That's V like Victor, I, T like Tom, A, S like Sam, vitas.com. And you can also reach out to Angie, and she'll be glad to get you in touch with me as well. Thank you. I appreciate your time and attention. Angie, do you have any questions?
Thank you so much, Linda, for doing this for us. I know a lot of folks, Linda was live a few weeks ago, and a lot of folks missed that. So I'm so grateful that you agreed to do this recording for us. I did want a question that comes up a lot, and you touched on it, but I thought maybe we could give some more concrete examples about it. But say a lot of people are worried that, well, there is this thought that if we call hospice, we're giving up, right? That this is it. And I think that's an attitude that through things like this and through different conversations we try and have with people, we try and alleviate that it's not, that's not what it is. It's not about giving up. But so you had touched on a little bit that, like, it doesn't mean that you can't have your physical therapy, or you have to get rid of all your medications or what have you. So you can be in hospice, say with dementia, and you fall and break a hip. That doesn't mean you're not going to get physical therapy, or you're not going to get help for your broken hip, because that's not related. Is that correct? I don't know if there's anything else you want to kind of address.
Yeah, so that's a really important point. And I think that that's a cultural, something that we need to work on culturally, is this, there's a mentality about hospice and about advanced illness in general. And the mentality is deny, fight until the bitter end, don't ever give up, don't ever give up. And so it's really unfortunate, because as illness advances, the burdens of treatment often start to outweigh the benefits of treatment. And so in a way, you are giving up quality of life, right? So you're fighting an illness, but it's a losing battle at some point. It's not a fair fight. And so what are you actually giving up at that point? You're giving up conversations with family, because you're spending 3 days a week for half a day in dialysis, and then you're coming home exhausted and sick, and you're giving up quality of life. You're giving up the opportunity for a peaceful death surrounded by your loved ones, and instead fighting until you die in an ICU where life is just robbed from you, like in a tragic accident. Instead of when we acknowledge that all life comes to an end and we make peace with that and accept that, then we can plan for a peaceful end. And it really makes a difference for the caregivers who are left behind when they know that that patient had a peaceful transition and surrounded by love and family, and that their last months and years were as high quality as possible. So that terminology, that mindset of giving up is a sad thing to see because it prevents people from taking advantage of this support. But you're right. So what you're talking about there is hospice is for the terminal diagnosis. If there is something unrelated to the terminal diagnosis, and your example is perfect, a fall, that's a broken bone, something like that, that is not part of the hospice, so you can have Medicare Part A cover that kind of, separate condition. In addition, on a limited basis too, sometimes therapy is a quality of life issue for a short period of time. And so hospice can, on a case-by-case basis, look at that situation and approve a certain number of treatments. So it's really not so black and white, and it's always better to inquire and have an assessment and find out about your particular case, what would be covered and what would not be covered. But I think it's really important to consider that it's not giving up, it's changing the model of care. It's not taking away care. It's a different model of care with different aims. So the aim of hospice is quality of life, pain and symptom management, holistic care, well-informed care, and it's compassionate and dignified. And, if we don't acknowledge that at some point death is going to happen, not acknowledging that does not stop it from happening. What happens is it just makes that ending much more harsh and painful for the patient and the family. So I'm glad you asked that. I really think I think it's just so important to have frequent conversations as things change. So, like, today I might say, absolutely, I want you to do everything. And then as my illness advances and I start to experience what do everything looks like, maybe I've had a code a few times and I've been intubated. Once I've experienced that, I might change my mind about if this happens again, do I want to go through that again? Dialysis is one thing that I see. People are not getting the opportunity to talk through and make really good informed decisions about this. So we know that as patients are older and have more comorbidities, those patients who get put on dialysis often don't have an opportunity to weigh the pros and cons. They just end up on dialysis. And most of the time, they regret that decision. Their quality of life is very greatly impacted, and the benefit of treatment is outweighing the burden of treatment. So it's really important, in my opinion, to be really proactive about looking down the road. What decisions are we facing? And let's have a good, honest conversation about what quality of life looks like and how much are we willing to sacrifice in terms of quality of life to get a few more days of life. And that's where the goals of care conversation, I think, is really helpful. It's an in-depth conversation. I come to it with no agenda. I just help them talk and think through and process thoughts and feelings. And, sometimes it's more than one conversation. It can last an hour. In one case, it lasted 4 hours, believe it or not. And that's the kind of thing that our medical team, our doctors and nurses who are working in acute care, they don't have the kind of time to have conversations that are that lengthy. And patients and families sometimes need a lot more time than they have to process a lot of these hard decisions. And what I can help those patients and families do is develop really good questions as well to take back to their care team so that they're really making sure that they're making informed decisions. And that's my passion and my goal is, that people are empowered with good information to make informed decisions that are in line with their goals, their wishes, their values, and that they have the ending that they choose, intentional end of life set, kind of scenarios.
I agree. I agree. I'm glad you brought that up. And I want to just reiterate and encourage folks, plead with folks to
Mhm.
call Linda or another. I mean, most hospice organizations have some kind of goals of care type program or conversation to have. And it's a great service that hospice organizations provide that we don't think about. They're not but it's that planning it and it's that thinking and having a third person, having an independent person in on that conversation is super important because if you're trying to talk with your spouse about a diagnosis you just received, you're both in shock, you both aren't quite sure, and maybe it's been a few years and you've been trying to manage symptoms and you've been trying to figure out where this is going, and the spouse who's sick may not want to tell their loved one that I don't want to do this I don't like going to the hospital, where
Mhm.
it comes out, they go into the hospital, then they're complaining about being in the hospital. And then the caregiver is like, well, you told me we're here. I made me call 911, but
Yeah.
you complain, you don't want to be here and you want to leave AMA. And what am I supposed to do with that? And how this is a personal thing for me. It's happened in my own family and it's so
Mhm.
hard. It's so
It
hard
is.
to have, but if there's an independent person who can just help you ask the right questions and think about things and really just help you clarify and talk about these really difficult things, it's so helpful. So I really just encourage people to reach out. I think um that's just so important. And then also, like you said, to go ahead if you have any questions about hospice, if you think maybe not today, but maybe 6 months from now, maybe a year from now, your loved one might need it. Go ahead and get that evaluation because then you have all the information and you know what symptoms, like you said, you know what symptoms you're looking for, and you can get that service as soon as possible because um, I have never heard anyone say they've regretted hospice. You know what I mean? Like you don't, that's just not a decision you regret. Most often it's, oh, we waited too long. We should have done
Exactly.
this months ago.
Right.
That's
And the
common.
important thing to know too is you're never stuck with the decision. So, if you have taken advantage of hospice care and then some miracle treatment comes along and you decide, I want to go pursue that, you're always able to revoke services. You're never held to that. And if you revoke and you change your mind a month later, you can always come back. So, it's not that kind of, I think that makes it a little easier to decide that it's not so rigid, like some health insurance plans are, where once you make the decision, you're stuck. You're not stuck. So, and it never hurts to get information. Absolutely. The earlier, the better.
Well, thank you very much, Linda, for taking
Thank
this time with
you.
us today. And if anybody has any further follow-up questions, Linda gave her information. You can also contact us at Catholic Charities. Our phone number is 513-869-4483, and we'll be happy to help you get in touch with whoever you need as well. So thanks, and everybody
Thank
have a
you.
blessed day.
Thank you.